Hey, good evening, everyone. Thank you guys for coming out to the ACOI student membership. Getting ready for residency panel. We have a nice topic tonight talking about urgent response. My name is Dr. Ranta. I'm a PGY1 internal medicine resident, and I'm going to help you guys out tonight. So here's some ACOI student membership. It's a free sign up if you go on the QR code. They'll give you updates about our club and give you some important details when applying to internal medicine residency and how to exceed and excel as a student. So here I am, Joshua Ranta, PGY1 internal medicine resident, part of the ACOI student lecture series for this year. And so the title of this presentation is Communication Under Pressure, Responding to an Urgent Situation. And so this goes out to everyone early in residency. Maybe it's your intern year and you're getting called for cross coverage or going to a rapid response, or maybe you're, in your early years of training still, maybe an early PGY2 or PGY3 who just wants to brush up on their skills. So we'll start with the clinical scenario. I'll have you picture this. It's 10 o'clock at night and you finally finish your last admit for the evening. Your pager goes off and the nurse is asking for you at the bedside. A cross-cover patient who you've never met before has unexpectedly taken a turn for the worse, and she's asking for a provider at the bedside now. So you're saying, wow, this nurse is asking me to come to the bedside now. What should I do? How do I respond? And so I think this is where a lot of us end up, especially when we're asked to make quick decisions. We can be looking like a deer in the headlights, as you see in the picture here. In medicine, as doctors and medical students, aspiring physicians, we're looked at with a certain amount of authority. We're looked at with you should have the answers. I need you to come and help and to figure out what's going on. Sometimes we have an idea of what this might be, but all the time we are maybe stunned a little bit in the beginning to figure out what exactly is happening, how we can respond. So we'll go through some steps for responding. So here we are, we just got this page. Now it's time to respond and do something about it. First step is to check your handoff. And so everyone who's done wards has seen this before. The cross coverage team gets handoff from the day team. Maybe you have a 68-year-old male with systolic heart failure, type 2 diabetes. He was admitted last night for acute on chronic heart failure exacerbation, and he presents shortness of breath. And maybe that's why the nurse is calling. And so that can lead you down a certain pathway just with the one-liner there. You might also have a 72-year-old male with substance use disorder, admitted for hypertensive emergency with developing abrupt back pain that doesn't seem to go away. It's more than it was before, and it's tearing from the front to the back. It might make you think a different pathology. Or finally, you have a 41-year-old female with history of IBS, admitted for pancreatitis on a PCA pump, suddenly not able to be aroused. And so just with this handoff, with this one-liner, you have an idea of what's going on. If the residents are good and the day team has prepared you well, there might be an if-then statement. If patient becomes short of breath, consider diuresis. If patient, develops abrupt onset back pain, consider a CT for aortic dissection. If, patient's unarousable, check the morphine mill equivalents given to the patient, maybe the pump malfunction or something like that. The if-then statement is perfect for you to look at as a covering resident, and it's a great thing to think about as a day team as well. So that's step one, is to check your page. Step two, if you have time, quickly review the chart for pertinent vitals, labs, and imaging. Ideally, this is less than 2 minutes. Like we said earlier, this is an urgent response, so not necessarily emergent. You're running to whatever room it is, but we'd like to get there within 5 or 10 minutes or so. So quickly go through the pertinent labs, vitals, imaging, all that stuff. And step three, we need to go see the patient. The nurse has asked maybe 5, 10 minutes ago for us to come to the bedside immediately. We need to get there. On the way, and maybe while you're pre-charting, ask nursing for an updated set of vitals. Has anything changed? Has the oxygen requirement increased? Has their PaO2 decreased? Blood pressure going up? Anything like that? All very important details to know. All right. So we've done all this prep work. It's 5 or 10 minutes in. We've arrived to the patient room. First thing you want to do is introduce yourself. As we know, sometimes in this cross coverage, We might not know the patient in front of us here at the bed. Maybe we get handoff on them, but we never met them formally. So introduce yourself, and also find the nurse with whom you're communicating. These nurses, they've been with these same patients, 4 to 6 to maybe even 8 patients all day. They can tell you what's changed and what's different. The first thing you want to do when you walk into the room when you're talking to the patient, assess if they're sick or not sick. You want to know if things are um, degrading rapidly, if they look uncomfortable, toxic appearing, if they look like they're in imminent danger, or if they're just mildly agitated, and maybe they miss their food or something like that. So here, vital signs are vital. So if the vital signs haven't changed much, that's a good sign that nothing is deteriorating too quickly. Whereas if oxygen requirements are going up, blood pressure is going down, other things like that, then you think you might need to respond a bit more appropriately. A few quick key questions you want to ask nursing. So, what's changed in clinical status? Why were you called? Maybe you were called because their O2 requirement has shot up. Maybe they just aspirated something. You want to know why there was a sudden change. Because, especially in the cross coverage team or maybe at the day team while you're doing notes, there's something different that's why the nurses called you. What medications have been given or held recently? Did we hold the diuretics because the patient's blood pressure was too low, or they couldn't handle it, or they refused? Or did we give them too many pain meds and that's why they're unarousable? All these things are good to ask. And then lastly, what is a clinical plan on the patient? Did they have a heart cath coming up in the morning? Was there an imaging study that a CTPE that has not been done yet that we need to get done? Always put, all these changes clinically in the story of their hospitalization. The next question is, do you need to intervene? So you've gotten all this information. Do I need to do anything? If you need to get more information, always go to the interview, examine the patient yourself with a physical exam, get repeat labs and imaging and EKG. Something important for you to remember a lot of times when you're wanting quick labs, quick electrolytes, and ABG or arterial blood gas can come with those electrolytes, potassium, lactate, sodium, all these things. So you can get those rather quickly. And then you got to think about, is there a quick fix or is there elevation in status? So is it a quick fix that we can give them diuretics and their shortness of breath goes away? Or are they becoming worse and worse as far as hypoxia goes and maybe need to be intubated or go to the MICU? So this is when we have to figure out who to call, whether that be call the ICU team, call respiratory therapy, or nurses. There's always going to be someone else to call. Just got to figure out who that might be. All right, so next we're talking about working as part of a team. So, how to bring up concerns early. So, as a physician and as a rising student physician, as you guys are, we're trained in clinical pathology. We're trained in recognizing early signs of systolic heart failure, of hypoxic respiratory failure, some other things. And so, we're always thinking diagnostically, how can we treat the underlying cause? And so, you might find that these patients have had these issues for a while, and there are small little things that can come together and come to a different diagnosis, right? And so bring up your concerns early. If you're unsure of a patient's clinical status, always ask for help, whether that's your senior or co-resident and attending if they happen to be around that day, or the ICU team, if the fellow can come down or the ICU attending can come assess in terms of airway or anything else that we need to assess. If patient is toxic appearing and sick, consider calling a rapid response. So at our facility, calling a rapid response will designate a certain group of individuals to come, a few rapid response nurses, a few others, and this will help you get orders in quickly, help you get imaging and labs back quickly as well, and help you make rapid decisions. I also will say it is helpful at some point to think aloud when putting together a differential, especially for patients you've never met. Nursing can help fill in key missing history, labs, or clinical tests that maybe rule in or rule out some of the things you're already thinking. Something else I'll touch on is closed loop communication here. Um, So this is vital with verbal orders. As a physician, you may not be able to access the computer while you're rapidly assessing the patient. You might ask for an EKG, a chest X-ray, arterial blood gas. So usually the nurse of the patient will put these orders in for you and you can sign them later. But just ask the nursing to confirm the order while they're typing it in. And so what they'll say is, yes, doctor, I heard you. I'm putting in the chest x-ray, EKG, and arterial blood gas in here for Mr. Smith right now. Also, closed loop communication is vital in high stress situations with lots of moving parts. And so if there are many people in the room, a lot of things going on, having this system of repeating back the orders and confirmation can really lead to a lot less errors. All right, and just an extra note on codes here. And so a lot of times here in rapid response, you get called to a patient's bed and they have a pulse. They may be a little bit tenuous, and then all of a sudden, you go to assess the patient and they've lost a radial pulse. So if they lose a radial pulse and they're not responsive, go more central. Find a femoral pulse. If you can't find that, it's time to call a code. And so I think usually going from rapid response to a code blue code situation is a big switch. We have to start compressions. We need to call a code team as well. I will say it's important for you as a physician to recognize these signs. Maybe you're the one who starts compressions, but you need to switch off as soon as possible. If there's another nurse in the room, if there are other medical students with you, or anyone else who's able to do these, switch off compressions, assign roles, whether that be, airway, compressions, medicines, um, timekeeper, recorder, stuff like that. Manage the others. This will allow you to think about what's going on and to be able to treat the underlying cause. Because if you're the one doing the compressions or searching for medicines, you won't be able to think about what you need to do next. I will say, remember your ABCs: airway, breathing, circulation. Remember full compressions. These are probably your highest yield as far as perfusing the brain. Attach the pads early with your AED device. You can put it on auto mode. This will help you determine the rhythm and assess need for shocks or anything like that. If you're nervous about using the wrong algorithm or missing something, these are usually found on the code cart. You can download it on a phone app as well. Even the most experienced clinicians have to use these every once in a while, so don't feel bad getting it out. You may catch something that you may have missed before if you don't. I will also say, like I echoed earlier, if you call a code, know which services are coming to help you at your hospital. So, for example, differences between a code team and a rapid team at our hospital. Anesthesia usually comes to a code. They'll intubate the patient if you need. An ICU fellows are required to come to a code, or an ICU attending usually comes as well. And so those people will be on the way, a lot more versed in critical care than you may be. And there may be some other services there as well. Last thing I'll say, just a tip for codes. The best codes are actually the most quiet ones. Don't be afraid to quiet down the room and allow others to focus. I think people, especially with many people in the room, sometimes 20, 25 people, it can get very loud. And especially, on regular wards teams where the nurses may not see very many codes, they may be a little bit frazzled and they may, just be a little nervous. So just quiet everyone down, allow each other to focus, and allow you to think about what's the underlying cause and what we can do. No one needs to yell. We can always just, speak quietly, confirm what we need to confirm, and keep going as a team. So next we'll talk about family updates. So we talked about rapid responses, how to approach those, what questions to ask, who to call, who to get involved. We talked about codes, as far as making that switch from a rapid response to losing a pulse and having to start a code. Um, who's coming, who to call, all that. Next is family updates. So usually this is either during or after the rapid response. Same thing with a code. The initial approach for family updates is to avoid medical jargon. A lot of these families are not familiar, obviously, with all the training and all of the clinical signs and symptoms that their family member may be exhibiting. So just give that all a grain of salt. I will say family calls at night for changes in clinical status only. There's no use in calling someone at 2 a.m. for something that can easily be treated. We can, you know, let them know in the morning. But let's say they elevate their care to step down unit or ICU unit, that is totally appropriate to call the family in the night and just let them know. First thing you want to do is ask their understanding of a patient's medical status. You may be speaking to a family member who has medical expertise. Maybe they were a nurse. Maybe they're just well read on a patient's chronic health condition. Or you may be talking to someone who has no idea what a hospital is and what we're doing. So just assess their understanding and you can meet them where they are. I'll also say just be honest. If causes are unknown, that's okay. So as you see here, our suspicion is the shortness of breath is related to his chronic lung disease and his heart failure. Not sure which one it actually is, but we're going to treat both and hope for the best that they'll get better. Um, I would say it's harder when you pin something down as a specific cause to go back. It's better when you don't know to keep things a little vague. You have suspicions and you'll look for confirmations later. Is probably the best way to explain it. Lastly, I say approaching delicate situations with clarity and empathy. If you are worried the patient's deteriorating rapidly, make your worries known. Doesn't mean you tell the family, I think he has, less than 1 day to live. But I would say, I'm worried, as far as his clinical status goes, we're not moving in the right direction. And I would advise um, you guys to follow up with the day team or you guys to follow up in person if available. Other things I would say is, as residents and students, we're in the hospital every day. This is our normal. We see people at their worst all the time. But this may be your patient and family's first time in the hospital. And so for them, this is a very scary thing. Even if it's a very treatable illness, treatable condition, they may not know that. And just being kind of delicate and empathetic towards them and their feelings. So finally, the aftermath. So we've kind of responded to an urgent code, an urgent message by the nurse. Things have either gone well and the patient's doing better, things have deteriorated and they've escalated to a higher level of care. In either case, we need to reflect. So residency is a time for growth. Same for medical students studying to be physicians as well. So we need to take time to reflect. This is best done with your co-residents, your attendings, or even the day team that had seen them that previous day with you. So assess what did we do well? Did we respond in an appropriate time? Did we fit things within the overall clinical picture? Did we identify the underlying cause of this acute decompensation? Or did we just treat what we saw? What can we do better next time? Could the handoff have been improved? Could we have scheduled earlier interventions with diuretics, quicker, more frequent? Could we be scheduling some bronchodilators or some other medications rather than just having them as needed, as the patient is likely not to ask for these things? And finally, identify issues that can be solved before it happens again. And this more is like upstream issues. Maybe you're missing equipment in the code cart. You had to send someone to go get an IO drill. Or maybe you were missing a couple other things that should have been there. And finally, look for earlier signs that may have been missed. Maybe this was a positional hypoxia and we didn't realize that there was a lot of water on the lungs. And so if we had done some ultrasounding or some other imaging before that, we could have seen these things. And so this is probably one of the most important things is growth and taking time to analyze what we did during the response and what we could do better next time. Don't be afraid to give yourself some positive feedback as well. This is time for growth, but not for, berating yourself. Don't be too hard on yourself. All right. And finally, just some clinical pearls. I would say residency is a time for your education and growth as a physician. There will be growing pains, like in anything, but these are necessary for you to develop into a competent clinician. So if there were never things that we didn't know what to do, we didn't know how to respond, we would never grow, we'd never learn anything. And so things will happen that you may not exactly know what to do, but If you respond with open communication, you do your best to frame the problem within the clinical context, and you communicate appropriately and ask for help when you need it, you will be okay, and you will do your best for the patient. All right, and that's pretty much it for today. So here's some contact us. You can email me. My email's down below. Can help you guys out with anything as far as internal medicine residency goes, or if you have any actual questions about my presentation today, let me know. Thank you guys so much and appreciate it.